Okay, welcome to part 3 of Care of the Cancer Patient. In this section, we're going to talk about some of the more specific effects of cancer and the treatment on the patient and the nursing care thereof. All right, so for those who are receiving chemotherapy, what we should know about the chemotherapy is that bone marrow suppression is probably one of the most common effects of chemo. Can also occur, but to a lesser extent with radiation. And both of them have, if they have both chemo and radiation, then higher risk. And so we'll talk about what that means as far as the care of the patient, because we talk about bone marrow suppression. That's where our blood cells are made, right? So our different blood cells that we have would be our whites, our reds, and our platelets. Then the hair follicles and also epithelial cells. So that's where most of the side effects that we're going to focus on the general care of the chemotherapy patient. And then we have some specific toxicities that occur as well. So most chemotherapeutic agents are excreted in the body fluid. So if you have a person that you're taking care of on chemotherapy, remember that their linens and their waste products should be kept separate. And if you're working in a hospital or something, most of the time these patients have yellow bags for their garbage and their linens so that they can be handled specifically to ensure the safety of the person that would be touching them. All right, so the side effects of chemotherapy, like we said, are going to be based on these. These are pretty much general to most chemotherapeutic agents. So severe anemia, which is the red blood cells, which can cause pretty severe fatigue. Remember, our red blood cells, they live about 120 days, so it takes longer for you to see these symptoms in your patient, but we can also treat this growth factors, so things like Aranesp or Procrit or erythropoietin, which we'll talk about later with these lectures and also under hematology, and transfusions as a last resort. And then reduced immunity from our white blood cells that occurs after somebody starts 1 to 2 weeks after with the neutrophils first. The nadir, which if this is a new term for you, nadir means the point when our counts are the lowest following chemotherapy, generally 7 to 10 days after the start of chemo. And the care of the patient there would be to protect them from infection at all costs. And then thrombocytopenia related to our platelets usually occurs 2 to 3 weeks after. We may have a spontaneous hemorrhage due to bleeding. So we focus on safety. Think about not giving them razors. They should use electric razors, not straining with bowel movements, fall precautions. And then we can also transfuse them platelets if they were to fall under 20,000. Mucositis, so sores of the mouth, that is a big quality of life issue. Chemotherapy-induced nausea and vomiting, and then constipation or diarrhea. So all of those have the potential to affect the patient greatly and impair their quality of life. So the one thing I think I would like to mention is the fatigue of chemo. So what is fatigue? It's persistent subjective tiredness, pretty much a universal complaint of patients with cancer, not always due to anemia, right? It can be due to the toxic buildup of cells, the energy of being sick and repairing meds, depression. And we often encourage people to use things like walking programs to kind of help with that fatigue and depression, which is also in your book. You can read about those a little bit. All right, so specific nod to stem cell toxicity. So if you see this hematopoietic, so that means the blood cells, right? We talk about that with our stem cells. So myelosuppression, that means suppression of the bone marrow, and that causes leukopenia, so decreased whites, anemia, decreased reds, thrombocytopenia. Be familiar with these terms. Of course, neutropenia, much more common in chemo because chemo is systemic and it will therefore always affect the bone marrow. Radiation, not as much, depends on where you're radiating. We will look at the fact that a neutropenic fever is a medical emergency, right? So by the time our person who has myelosuppression is able to even mount a fever, it's usually because they're septic. And the number one killer for patients with cancer is infection and nadir, right? So that's the concept I want you to be familiar with. Nadir, the absolute neutrophil count, reaches the lowest point. So this has wide implications for us. So the first is that if somebody already has a problem and they haven't reached their nadir, it means that they're going to get worse. We can anticipate that, right? That they haven't even reached the lowest point in their counts. And additionally, that it is an emergency. If somebody's got signs of an infection and they're not even at their nadir, I mean, we have to move. We have to do this. May be life-saving. So how do we figure out the absolute neutrophil count? Here it is. You take the neutrophil percent plus the bands and then multiply that by your total white blood cell count and divide that by 100. So you can see the sample here. White blood cell count is at 6,000. Neutrophils are at 30 and bands are 3. So it's 33 times 6,000, which is 1,980. So in this case, the person is not neutropenic, right? Because they're 1,980 and the range is 1,500 to 8,000. Very wide range. A person is said to have, honestly, the neutropenia under 500,000 or 500 means severe risk of infection. I believe that they may actually be neutropenic at 1,000. So, but I will clarify that in class. All right. So, how do we increase the white count? How do we protect people from infection? So, the one that we are often using are things called granulocyte colony stimulating factors, Neupogen, filgrastim. So you're going to see them. Their generics would end with stim, so they're stimulating. So, or you may see them listed as GCSF, granulocyte colony stimulating factor. So basically, that tells the bone marrow to produce white cells, especially neutrophils. Because it's causing that, bone pain is expected. These are usually given subcutaneous. And now we have some that are actually, the person gets them placed in chemotherapy, and then it releases the medication sometime after, whether it's 24, 48 hours, I'm not sure, but it's time released so that it will give the injection when it's time. And then erythropoietin, we use that for the red blood cells. And you'll see this much more commonly than you will see filgrastim because we use erythropoietin in our patients with chronic kidney disease as well. So people with chronic renal failure, some folks who have other medications, people, different reasons they might have it, but it is stimulates the production of red blood cells. So what do you need to know about this? Anytime we're giving an increase of something, we have to think about what happens if we have too many. So they can end up with an increased hematocrit, CVAs and strokes, because if we have too many red blood cells, those can get clumpy and they can cause that as a side effect, high blood pressure, hypertension. So for this reason, we don't want to give them something they don't need. So you're responsible for monitoring the patient's lab studies, whether they're getting filgrastim or Epigen. you have to know which one goes with which. If I'm giving a granulocyte colony stimulating factor and I'm looking at their hemoglobin, then that's not the right lab, is it? So erythropoietin, we do not give it if their hemoglobin is over 12. So you need to know that before you give it. And thrombopoietin, Doptelet, is actually a pill. It produces megakaryocytes, which are the precursor for our platelets. Oftentimes, you're not going to see this as a very common medication given, but you will occasionally give platelets. So there are some rules for giving platelets. The biggest one is that we don't give platelets unless they fall under 20,000. All right, so let's go on to the next thing, some of the GI effects, okay? So GI effects, some of the most common you're going to see, mucositis, stomatitis, and because of that, we really need to give prophylactic administration of the antiemetics. It is underreported and undertreated. That's why we recommend prophylactic treatment. You need to make sure that if your person is vomiting, that you monitor them for alkalosis, dehydration, watch their eyes and nose. And basically, depending on what's going on, whether they have constipation or diarrhea, we want to target the diet for them, right? So people who have diarrhea, they would need low fiber, high calorie, high protein is across the board for cancer. But in general, low fiber, low residue for diarrhea, increased fluids for diarrhea, antidiarrheals for diarrhea. And if it's constipation, on the other hand, we'd want to increase the fluids, give them their high fiber foods, some stool softeners, and make sure they know not to strain. For mucositis and stomatitis, we might give them BMX solution, so magic mouthwash. It's betamethasone, Maalox, and xylocaine. So it has, or I'm sorry, not betamethasone, but Benadryl. Artificial saliva to keep them moist. And then for their diet, you would want a moist, bland, soft diet. And anorexia, of course, monitor their weight frequently and monitor carefully. They might need supplementations. There's medications we can give them. Megace, so Megastrol is one of them listed here. We have some of the cannabinoid derivatives, so THC and the like. A little bit more about how we treat chemotherapy-induced nausea and vomiting. The way somebody is vomiting can actually affect so much of their cancer treatment. They need to keep their nutrition up. It's such a quality of life downer here that people may not continue on. So you're responsible to know your medications. Even if you don't necessarily know the med, one of the things you can look at is what is the ending of the med. So see these? They end in cetron. Cetron. So what does that mean that they are? Like, those are serotonin receptor blockers. So start using some critical thinking to look at the medications and see how it will go. Corticosteroids, so dexamethasone, probably one of the more common ones that you'll see. We give that frequently even post-op, so dexamethasone. Some people get nausea and vomiting even just thinking about their chemo. It's called anticipatory. And if that's the case, then they definitely need prophylactic antiemetics and even anti-anxiety medications before their chemo. And then people who are having nausea and vomiting, believe it or not, a carbonated beverage before meals can help. So something that I found out, it would seem to go contrary to what we've been taught, but nope, it actually works. All right, so the kidneys. If this is one of your first lectures with me, let me introduce you right now to my love of all things kidney. All right, I love kidneys. The left kidney, the right kidney, oh, musical. So many of these medications can cause nephrotoxicity. So some of them would be SIADH, which we'll talk about under our oncological emergencies. Tumor cell lysis, so as those cells get destroyed, they release uric acid, well, they release the precursor to it, and the uric acid then gets formed, but all the same, the result is uric acid. And that uric acid could cause crystals, which can lodge into the kidneys and damage them. So the things we need to monitor for nephrotoxicity would be our potassium levels, our BUN, creatinine. The way that we try and solve many of these things like tumor lysis syndrome is to increase urine output. So we need to give them massive hydration. Some of the other things that can happen, like cyclophosphamide causes hemorrhagic cystitis, cisplatin, methotrexate, all of those are known for messing with the kidneys. All right, cardiopulmonary. So certain medications can cause this, and they can cause it as delayed as well. So just be aware of patients' histories. So cardiac, doxorubicin. This is this is why certain medications, they only have a lifetime limit on it. So like even if they had a recurrence of cancer, they couldn't go back to the same meds because they can cause cumulative effects. So if somebody's having cardiac issues, what might I see, right? Reduced ejection fraction, signs of heart failure. Could be left-sided, could be right-sided. And then respiratory, we'll see those in the lungs. Could cause things like wheezing, bronchi, pulmonary leak, so capillary leakage. You'll see it with cough, difficulty breathing, shortness of breath. So what do we need? We need a lung assessment, and we need patient teaching. And then neurologic toxicity. So some can cause encephalopathy. Some cause peripheral neuropathy, so whether they work on the central nervous or peripheral nervous system. Many medications are ototoxic. And then there's something called chemobrain. So chemobrain is actually a thing that can happen as a cognitive impairment. It can be mild to severe. It can be short-term or long-term. But it's something that we need to look out for and provide patient teaching on. And the rule with reproductive toxicity is really protect what you can. Age and status really are important prior to treatment to give them that choice for preserving their reproductive ability. And the other thing, not often talked about, but some things can cause erectile dysfunction, including pelvic radiation. So you need to teach the patient on this. Many of these meds, all of them, for the most part, are teratogenic, which means that they will harm a fetus. So people need to know this teaching and use reliable birth control. So in all of these, just remember that long-term effects may not show up, right? As far as we're taking care of them, might be sometime later. So you need to always be assessing patients with a history of cancer, and also the risk of secondary cancers as a result. It's a common thing. We're giving somebody some medications to cure cancer that can cause damages to the DNA of other cells, which down the line would cause another cancer. Some of the most common, I think, are the alkylating agents. All right, so let's continue on here to stem cell transplantation. So there's different types of stem cell transplants, and we'll learn more about these under hematology with some of our leukemias, but it's important to start talking about them now. So it can be from a person, the same person, right? I could give myself my own bone marrow or stem cells, which usually if you're dealing with cancer, not a great idea because we don't know what kind of cancer cells we may just be reinfusing to the patient. So it's often not performed on those with cancer, not autologous. Allogenic, this is from somebody other than you, right? Could be a relative, could be just a donor from the registry. Umbilical cord. Great stem cells in umbilical cord blood, but may not always be available for people and may not be enough. And then the thing where it says myeloablative. So basically, if we're doing a stem cell transplant, basically in order for the person to get the cells to implant into their body, you have to kill their own immune system by using high dose chemo. You might radiate the whole body. So here is autologous. So you would only use that if there's no donor match, and yet your bone marrow is healthy. So again, the big disadvantage is that the cancer cells may remain in the marrow, but the positive is that they don't need immunosuppressants. So they're not going to get graft versus host disease or host versus graft. All right, let's talk about harvesting the stem cells from the person. They might be general anesthesia, but for the most part, it's spinal anesthesia or local. You might get it from the iliac crest or the sternum. Most common is the iliac crest. It is not pain-free under local. The person will feel some pain with the needle itself as they're, especially for like biopsying. What they do is they pull the bone marrow and preserve it until infused, and then if you were to give it through outpatient peripheral blood, it's just literally giving blood. They freeze out the stem cells, and then the other cells get turned back to them. So those are them, and you guys are responsible to know the care of the patient following the bone marrow biopsy or harvest. So we'll talk about that too. All right, so when we do myeloablative allo stem cell transplant, basically the person that's getting the transplant will need high-dose chemoradiation. And then the person's stem cells are infused, and then we would hope that within 2 to 4 weeks that those stem cells have gone to work and are now producing reds and whites and platelets. But until that happens, the person is at high risk for infection and bleeding. So there are some acute side effects and then some chronic side effects of having these done. So just take a peek at those. All right, so post-transplant, the biggest complications we're going to see is severe pancytopenia initially. That we need to support the patient through, whether it's through blood transfusions, giving them basically keeping them safe from infection. The person could get severe infection, so they're often on prophylactic antibiotics. And then there's something called graft versus host disease, which we will talk about in more detail coming up here. So little nod, of course, to the anemia that the person is going to have, so balancing rest and activity. Neutropenia, again, if this is the, okay, so here we are, the criteria for neutropenia, less than 500, or if it's less than 1,000, but they're predicted to decline, so they haven't met their nadir. So neutropenic fever, the criteria is any one-time temp, 38.3, or any temp greater than 38 for over an hour. So if that happens, then we have to culture that patient and get them started on antibiotics right away. Most important would be drawing those cultures. It's always number one. Before you give any antibiotic, get the cultures. And then bleeding and hemorrhage. Thrombocytopenia is listed here. So platelets under 100,000 is thrombocytopenia. Bleeding risk increasing 20 to 50, but then under 20 is spontaneous bleeding. So again, we will talk about that a little bit more under our hematology section, but understand that anybody who has the potential for bleeding, we need to keep them safe. We already know how to do it, so let's pull from previous semesters on how to keep people safe from bleeding. All right, so now let's go to graft versus host disease. So graft versus host, basically, when we do the stem cell transplant, what we hope is that the new immune system comes in and beats the snot out of the cancer. Sometimes what happens, though, so that would be like the graft versus leukemia effect. So we do this a lot for leukemias. But sometimes what happens is instead the graft, so the immune system that the person has been transplanted, recognizes the person as foreign. So it'd be like me giving my stem cells to my sister and them setting up shop over there and then not recognizing my sister. And so instead the cells go to war against my sister, right? So it's going against the host. This is an important slide for you to remember, right? Graft versus host disease. There is a triad of symptoms. They are dermatitis, enteritis, hepatitis. So what does that look like? It looks like skin rashes, right? Usually on the palm, can be severe, peeling skin. It could be liver and GI involvement. When we say hepatitis, that means liver inflammation. So what are the signs of hepatitis? GI involvement. It could be diarrhea. The person have jaundice. So this is a very important thing. The reason why it's so important is because if we are able to get in and sooner, like if we can start treating it sooner, they might have a chance. But if we see this, the chance, the person, if we can't get it under control, they're going to need a new stem cell transplant, and they may not be even healthy enough to survive it. So there's risk factors for getting graft versus host. One is that you don't have a good match. The patient is older, if you have a female who's donating to a male, and basically how good the chemo and radiation was. So this is acute graft versus host, so see that's acute. There is chronic, right? Chronic can often be treated with steroids. So, or we could go from acute, get the steroids, and it becomes chronic. It can be very mild. It could be all the way up to life-threatening. So here's the differences in signs and symptoms. So you can pause on that and take it. But remember, the signs that we're looking for are acute, dermatitis, hepatitis, enteritis. So here's the treatment: cyclosporin, methotrexate, tacrolimus, which you've probably, maybe you remember, if it was taught, was an anti-rejection medication. How to prevent it: better matching. Sometimes if we really can't, we do what we can. All right, so here's the nursing guidelines for just general treatment of patients with cancer and who are on chemotherapy. Report your fevers. It's an absolute medical emergency. Culture and sensitivity prior to any antibiotic. That's, very important. Reverse isolation for people with low ANCs. Taking care of dressing changes the way they're supposed to be to avoid staph. Avoiding IM injections and using the smallest gauge needle possible for a task for somebody who's got pancytopenia or thrombocytopenia. Avoid invasive procedures like Foley catheters and the like. Avoiding taking rectal temps makes sense, right? If somebody's at risk for bleeding and infection, we don't want to do invasive procedures on them. We can teach the patient how to administer their own medications for home use, like their Neupogen or Epigen. Oral health is very important, and also a person who's going to have any oral care or oral treatments while they're on chemotherapy and have bone marrow suppression or at increased risk of bleeding. keeping your patients safe and avoiding any crowds. This is where like taking care of patients comes into play. Like the registered nurse is generally tasked with making room assignments for patients. So if you have somebody who has potential to have a weakened immune system, you have to put them with appropriate people. Do not place them with people with infection. And then using disposable equipment for them is much preferred. Otherwise, changing things out daily for them. All right. Pain. Pain, people who have cancer diagnosis often comes along with pain. So for these folks, opioids are generally used with the basically this says OTC. It means to say around the clock. So let me fix that for you. Around the clock, and breakthrough dosages may be needed. It's not uncommon to see fentanyl patches and things like OxyContin, long acting. But understand if we give a pain medication, it can cause constipation, so be aware for that. And then some of the other meds we don't use all the time, but we for their intended purposes, but we'll see them as adjuncts for pain. Some of the antidepressants, the anti-seizure meds. And then remember that there's a lot of things that can be done that are actually not drug related, and those do have a role in nursing. If somebody complains of pain, the thing that you have to do as a nurse is to make sure you have a good history of the pain, good assessment of their pain, so that we know how to treat it and we know what's working and isn't working. We've already kind of talked about some of these things like the stomatitis and mucositis. So basically, how do we treat it? Saliva substitutes, good oral care. Some people might need antibiotics. We monitor them for candidiasis. All right, cancer-related anorexia-CACHEXIA syndrome also is a wasting syndrome. So sometimes you'll see cancer wasting. So again, Megase would be the appetite stimulant. There are some others. High protein, high calorie diet. Guys, you have to know your diet. Monitor their albumin and the pre-albumin levels, because those have a lot to do with how well a patient does for treatment. And the person may actually need enteral or parenteral nutrition. Enteral is always the preferred nutrition. All right, we want people's digestive tracts digesting if they can. It's a normal physiologic function. Some people may not be able to take everything in by mouth based on the type of cancer, the surgeries, and we might need a prophylactic PEG tube placement with certain surgeries just to make sure the person is fed. All right, and one of the last things we're going to talk about under this section is survivorship, right? For the time they're diagnosed to the rest of their life. And we have to, as nurses, look at their needs. We need to know what meds they took. We need to know how long ago, what the basically monitoring is, looking for secondary cancers, long-term effects of the chemotherapy. Like if I know somebody had doxorubicin, then I'm going to be worried about cardiotoxicity. I might, if they're complaining of some chest pain or shortness of breath, I might pull them in sooner, right, than to make sure that they don't have cardiotoxicity as a result of it. And some of the other side effects for cancer care, somebody might be left with lymphedema, taking care of the person who maybe wants to have a child afterwards. So it's not a one and done. Cancer is a lifetime diagnosis. Right, so that's the end of part 3.